Record. Okay. I'm thrilled to be with you here today to talk about the critical role of perioperative nutrition in our patients' outcomes and the opportunity we all have to do better for our patients and give them the best outcomes possible. The key message that I hope I leave all of you with here today is that no malnourished patient should ever have elective surgery without nutrition screening and optimization. And unfortunately, this is happening around the US and around the world every day. And you are the people, because you're here listening to this lecture and passionate about making a difference, you're the ones that can change this. Because the reality is, training for surgery or preparing for surgery is like training for a marathon. And this is the marathon of many of these patients' lives, because they are literally fighting for their lives when they have these major cancer and other abdominal surgeries. And so we have to train patients like we would someone training for a marathon. And that's where the right nutrition, the right carb loading, the right hydration, all these things that we do for patients with nutrition are very similar to what an elite athlete would have to do training for a marathon. Only in this case, again, this is the marathon of our patients' lives. And again, it's not the marathon of the road, it's the marathon day table, the operating room table that we're preparing for them. What happens when we ask our patients to run the marathon of their lives without training? And so I want to talk to you about a patient that I took care of once, who I think exemplifies what happens when we don't train our patients. And this young man was named Joshua. He was a 23-year-old patient with inflammatory bowel disease presenting for an elective colectomy. As you can see, he presented with a BMI of 18 and a 40-pound weight loss over the last 3 months, as is so common in IBD patients. Now, unfortunately, he presented on a Friday in the preoperative clinic for surgery on a Monday, just 2 days away. So difficult to actually get anything optimized, especially when it comes to nutrition in this very short time. So ideally, perhaps, the question is he ready for surgery? And the reality is he's not, and we should probably delay this surgery to ensure he's optimized for this surgical procedure he's going to undergo. Unfortunately, that didn't happen, and Joshua went to surgery. And he did okay for the first few days after surgery, but then on day 3, he developed a cough and a fever and was diagnosed with pneumonia and started on antibiotics. Unfortunately, later in the day, this progressed to septic shock, disseminated intravascular coagulation, and massive abdominal bleeding. And the physicians at the outside hospital didn't think they could care for Joshua. And so they sent him to the academic hospital where I worked to deal with this massive abdominal bleeding and septic shock. When he arrived to our hospital, we took Joshua to the operating room where we evacuated and stopped the bleeding. And then ultimately he presented to the ICU where I met him for the first time with an open abdomen due to the abdominal and intestinal edema from his shock state, and then ARDS as well because of his prolonged shock. And Joshua went through all the things our critically ill surgical patients go through, including, unfortunately, poor nutrition. And what does that look like? Because this happens, unfortunately, all the time around the world. Well, first, no pre-op nutrition assessment or intervention was provided to Joshua, despite needing this desperately. And of course, he was made NPO waiting for bowel sounds, which we know has no relationship to the ability to feed patients. And the reality is he should have been fed immediately day 1 post-op, because shortly thereafter, when he was fed, he started to vomit. And that's because he developed an ileus, not from the surgeon, but because of iatrogenesis. So if the bowel is not fed within 24 hours of a major stress, it becomes akinetic and you can't feed it. For instance, in burn, I used to do burn care. If you feed a burn patient within an hour of admission, you'll feed them for a month. If you wait 24 hours to try to feed a burn patient, their stomach won't tolerate it. They'll have residuals and vomiting. They won't tolerate it at all. And so Joshua had vomiting after we tried to feed him, and he tolerated about half of his nutritional needs for the next week, because we know it takes an act of God to start tube feeds, but unfortunately the nurse going to lunch or a CT scan being ordered to stop tube feeds. And so he got much less than his needs would have been prescribed to be. So despite all this, Joshua weaned on the ventilator, although quite slowly, and unfortunately became very weak. But despite that, he was discharged from the ICU 48 days later, not home, but to a long-term care unit, to a rehab unit. And we as the physicians applauded ourselves. We applauded ourselves. And so the question really is, was he a success? Now, of course, we as the physicians and the care team thought he was a success because he was leaving the hospital, right? He must be better. But I asked Joshua how he felt about things the day he left the hospital. And this is what he told me. He said, I'm glad I'm leaving the hospital to go to rehab, but I have a few concerns. One is I can't feed myself or swallow. My muscles on my throat are too weak and I have to learn how to swallow again. Next, he said, I can't stand, walk, or dress myself because I'm too weak to get out of bed. But none of these was his number one complaint. His number one complaint was this: I can't even change the television channel with the remote because my hands are too weak. They're too weak. And so he goes off to rehabilitation, and his dad calls me about a month later, and I'm excited to hear how Joshua's doing. And his dad tells me Joshua was walking in the hall just the day before, trying to get better, when suddenly he has chest pain and a feeling of doom comes upon him. Moments later, Joshua was found in PEA cardiac arrest on the hallway floor of the rehab unit. He gets 40 minutes of CPR laying in the hallway of the rehab unit. And then moments later, Joshua is declared dead. What did he die of? You can imagine. He died of a pulmonary embolus, which was found on autopsy. He had developed a DVT from immobility that wasn't detected, and this ultimately led to the PE that took his life. What happened to this patient, right? He should have lived. He was a young man in his 20s. We cured his sepsis. We treated his IBD. We got him out of the ICU. What did he actually die of? He died of this. He died of malnutrition, and it happened right under my nose, which is one of the many reasons I'm so passionate about nutrition and its key role in improving the outcomes of our surgical patients. Because the reality was nutrition was neglected in this young man, and it was an emergency for this patient, as it is for, I will show you, many of our patients. And we need to do better. And we'll talk about how. But first, how common is malnutrition in our surgical patients? How many patients are like Joshua out there that we are not treating every day for their malnutrition, and their outcomes are the worst because of it? Well, the reality is 2 out of every 3 patients coming for GI surgery are malnourished when they arrive to the operating room. So before they're ever hospitalized, they're already malnourished, a majority of them. And the reality is this has a significant impact on outcome. If you have cancer surgery, GI cancer surgery, and you haven't lost weight and are well nourished, your mortality is very, very low. You're going to survive the surgery. If you have lost weight prior to your operation, you have a 5-fold increase in your mortality after the operation. 5-fold increase, actually more than that. And so this is a significant effect. And the reality is, although albumin is not a great marker of malnutrition, it's a marker that our surgeons really listen to when it's low, and we know it increases risk before surgery. But the reality is, if you look at the 2 million patient NISQIP surgical database from the US, it shows that the way they diagnose malnutrition via the albumin less than 3.5, patients with an albumin less than 3.5, that's the number 4 predictor of death at 30 days from any inpatient operation. Number 4 cause of death. And if you look at all the things on this list, the only thing we have a chance to modify or improve in the 7 to 10 days before surgery is the nutritional state of the patient, perhaps measured by the albumin and other, hopefully more objective markers. And so again, this nutrition state is the only modifiable risk factor we have in the preoperative setting to improve our patients' outcomes in the short term, 7 to 10 days before surgery, that are major causes of death. So why don't we pay more attention to it? Well, the reality is because the patients that die of malnutrition so frequently die after they leave the hospital. So we as the caregivers never see what actually has happened to them. And so again, Joshua left the hospital, but a month later, he died of his malnutrition. I think this is why this doesn't get more attention, because a lot of these deaths are occurring after the hospitalization. So again, this is an emergency. Malnutrition is an emergency in surgery, and we have to be better. And so how can we do that? Well, we have a great opportunity using the new and exciting ERAS enhanced recovery programs. I'm sure you've heard of it. Perhaps you're doing it. Duke was the first major U.S. hospital to do ERAS, so we've been doing it for a long time here. And if you've done ERAS or heard about it, it is truly awesome. But I don't do awesome so well, but I know some people who do awesome better than anyone. And I want you to listen as they talk about the role of nutrition in ERAS. Listen closely.
You got to sign.
Why are you guys going so fast?
Beep, beep. We're on the fast track. Hmm? Why are those guys going so fast? And what's fast track?
Oh, you must mean fast track surgery. We call it ERAS.
ERAS?
Yeah, it stands for Enhanced Recovery After Surgery.
So what's the deal with it?
Well, let me tell you about it. So, ERAS is a program designed to help people recover more easily from surgery. Only before any type of bowel surgery, we would stop patients from eating and give them a strong laxative.
Yeah, that's what I had. I was starving and had diarrhea.
Yep, it makes you pretty dehydrated.
Those pesky residents come around every morning asking if I had pooped.
Hey, Dan, have you pooped?
No.
It's been a week after my surgery, and I still haven't pooped.
Thanks for sharing that, Janie. So let's look at what happens in the new ERAS program. We're changing what we do before, during, and after surgery. And they can eat real food up until 8 hours before the surgery.
So I can have supper the night before the surgery?
Yeah, of course. As long as it's just a light meal, no donaires or anything crazy like that. And you can even drink some juice on the morning of the surgery, up to 3 hours before go time.
Awesome.
One, go. Have you heard the news? Everyone's talking. Close looks good because everyone's walking. An operation where recovery's faster. Limit of cards like a master. I really like ERAS and passing gas. I'm eating all the food and I easily pass. 2 days later, eating the forecast, feeling like a boss. ERAS is awesome. Stepped on my bed, grabbed my skateboard. It's awesome to move. It's awesome to poop. It's awesome to poop. It's awesome to poop.
So ERAS is truly awesome, as you can see. And the reality of ERAS, or the intent of ERAS, is that we can take a patient who perhaps is still smoking, perhaps has uncontrolled diabetes, perhaps is not fit, perhaps is malnourished, and improve their functional and other health statuses before they come for their major operation. In other words, train them for the marathon of surgery. And so that's the intent of what ERAS does. And it has multiple components. And it includes care that starts from the preoperative and goes all the way through the postoperative portion of a patient's care in and around surgery. And nutrition plays a key role in every aspect of ERAS and in all the different facets of ERAS. You'd think, though, with all these complicated things that we have to do in ERAS, the nutrition would be the easiest part, right? And that all of our patients would be getting nutrition addressed before and after surgery. This is my youngest son, who's now 13, but when he was 2 and 3, he was able to meet his nutritional needs without a problem. But unfortunately, our surgical patients are not meeting their needs. And so, again, we need to be better. And so I want to ask you guys a question. You just got a hint, but how many of our patients are NPO'd at any given time in our hospitals? Well, in the state of New York, they did a really interesting study. And they looked at how many patients on a given day were NPO in all of the hospital beds in the state of New York. And I want you to take a guess at how many that was. The reality was our patients are not getting their malnutrition addressed, and almost 50% of patients were NPO on any given day when they did this survey. So again, 40% of patients, 43% are NPO on any given day. So again, if I ran a prison and didn't feed half the prisoners, they would fire me. But somehow it seems to be okay that we're not feeding our patients who have perhaps the most metabolic and nutritional need after their operations and with their illnesses. So again, malnutrition is an emergency in our surgical patients, and we have to be better. But how can we do that? Well, to try to address this question, we put together a group of surgical anesthesia, dietitian, and other perioperative experts. And this was put together by the evidence-based perioperative medicine group. And we came together as experts to look at what evidence was for the best possible nutrition care for our patients. We published it in one of the major perioperative journals. And these are what the things we found were. Again, we found that 2 out of every 3 patients coming for major GI surgery were malnourished, and that this malnutrition led to a 5-fold increase in death if it was present when someone had an operation. The unfortunate part was only 1 in 5 of the major academic cancer and GI surgery programs around the US, these are the best programs around the US. When we did a survey, only 1 in 5 had a formal nutrition screening process. Although virtually all the surgeons we surveyed said and believed that if we improve patients' nutritional status, that we would improve their outcomes. And in fact, a 1.5 million patient study showed that every dollar we spend on the little high-protein oral nutrition supplement drinks that are so essential to pre-op nutrition and post-op nutrition, every $1 we spend on those, we save $50 in hospital costs. But only 1 out of 5 malnourished patients are actually receiving these simple, effective, high-protein oral nutrition supplements or any pre-op nutrition at all when they're malnourished. So we wanted to make it simple around the things you can do and people could do to improve patients' outcome nutritionally around surgery. And one is nutrition screening is essential. You won't find malnutrition if you don't look for it. Protein is more important than calories in both pre-op and post-operative state. We need to stop feeding later and later. MPO from midnight is not something we need to do anymore, and we need to restart feeding the day of surgery. Oral nutrition supplements are essential for all patients, malnourished or not. Oral before parenteral, and nutrition management is a team game. We need our dietitians, our anesthesiologists, our surgeons, our nurses. Everybody needs to be on board to make sure our patients receive the best nutrition. So to talk about how we can best implement these guidelines, let's talk about another patient I cared for a number of years ago. Her name was Michelle, and she had colon cancer, and she was coming for a colectomy. Again, she had a low BMI when she came to pre-op. She'd lost about 6 kilos due to some bowel mass and some partial bowel obstruction for having a poor appetite, and her albumin was very low. So how can we simply and quickly evaluate all the patients in an institution or a hospital coming for surgery? Well, to do this, we as a group developed the perioperative nutrition screen, a surgical specific nutrition screening set of questions using validated questions from other nutrition scores to rapidly evaluate patients in the electronic medical record. And we've built this into our electronic medical record at Duke, and we screen all 60,000 patients at Duke having surgery with this nutrition screen via a phone call they get before they have surgery. And the questions are simple. Do they have a low BMI? We derive that from the chart. We ask them if they've lost more than 10 pounds of weight in the last 3 months without trying. Have you been eating less than half of what you normally eat? And do they have an albumin less than 3.5? If the answer to any of these questions are yes, we refer them to an RD-driven perioperative nutrition clinic and to our prescribed nutrition pathways, which I'll show you now. They're simple and straightforward. So these are the pathways we use that you can start using tomorrow. If they don't show any risk factors for malnutrition, low nutrition risk, we still give them immunonutrition for 7 days pre-op. Everyone should get that. And carb loading 2 hours before anesthesia. And then post-op, we give the immunonutrition for 7 more days. Then we give a high-protein H&B containing oral nutrition supplement for 4 weeks. If they do have risk factors for malnutrition, they get referred to our RD-driven nutrition clinic. They get 4 weeks, with ideally, of a high-protein H&B containing ONS, although we will take even just a week. We know that can improve outcome. They get the immunonutrition for 7 days and the carb load. And then post-op, they get the immunonutrition for 7 more days and then the high-protein H&B containing ONS for 4 weeks. And this malnutrition group has the RD call them weekly to assess compliance and to answer questions and to help the patients work through how best to stay on these pathways. So these are pathways you can use now. So what about Michelle? How did she score? Well, she had risk factors on all the questions. She was yes on every question. So she had a PONS score of 4. And so she was very high risk. Now, again, a lot of the questions on the PONS score are subjective or have limitations like the albumin. And so the future, we believe, is the evaluation of muscle mass and lean body mass via CT scan, which we recommend. You can also do this by ultrasound to actually objectively predict risk prior to surgery. Well, many of our patients, especially having GI surgery, already get CT scans, and with simple free software made by Slice-O-Matic, you can measure your patient's muscle mass state from the already existing CT scan. Now, I will tell you, some of the radiologists, both at Duke and at Harvard, have already developed single slice CT scan technology that delivers less radiation than a chest X-ray and can be used to measure muscle mass with a single quick slice. And I'll tell you that the Harvard group has already found a way to report out muscle mass and bill Medicare successfully for this. So this is the future. And we know that low muscle mass or sarcopenia is significantly associated with increased mortality and increased complications following many different kinds of surgery. This is just the data for pancreatic cancer, but there's data like this for many different kinds of surgery. And so could muscle mass and quality, perhaps by ultrasound or CT, be the future of perioperative nutrition risk diagnosis? We think so. And so CT scans are already in use. Ultrasound is something you can do at the bedside. BA is another technique. And this is all consistent with the GLIM, the Global Institute for Malnutrition's new criteria on how all of us should be diagnosing malnutrition. And they say reduced muscle mass is a key criteria we should be using objectively to diagnose malnutrition. And we look forward to adding this to the PONS score by the creation of a perioperative sarcopenia risk index. And we're working on that now here at Duke, and other places are working with us. So how should we treat Michelle's perioperative malnutrition? And if we would have identified and treated Joshua's malnutrition, could we perhaps have prevented his post-surgical infection? And what does the data say for that? Perhaps we could have saved his life. So first off, we recommend that reaching a protein goal is more important than a total calorie goal in the preoperative period. And we need to get above 1.2 grams per kilo per day. Why is that? Well, we know that when the body is stressed, whether it's hit by a tiger or hit by a surgeon, we break down our muscle to generate amino acids and glucose to escape the tiger or the surgeon, and also to fuel our immune system. And the reality is, a well-nourished patient, the body can generate 50 to 75% of the glucose requirements that the body has. So a lot of exogenous glucose calories aren't necessarily the key thing the patient needs, but protein delivery is essential because we want to try to reverse and prevent that weight loss and muscle loss and the loss of function that goes with it. And I'll talk about the fact that perhaps patients don't have to lose muscle mass after surgery. We'll come back to that. Because the reality is you can't build a house without bricks, and you can't maintain and rebuild muscle without protein. It's fundamental. And so I think it's really critical here that we also understand the concept of anabolic resistance. And that concept says that it takes more grams of protein to build muscle as we age than it did when we were young. So again, more protein grams are needed to build muscle as we get older than when we're young. And that's what anabolic resistance is. Now, not everyone who's older loses muscle mass. This gentleman's 70 years old and does pretty well, but he does more than just eat right? But we can learn a lot from athletes. And the athletes have shown us that they have to get enough protein in, that taking in his bolus is probably the best, and that taking it in before our patients go to bed at night is the ideal way to build muscle mass. And the reason is because we're anabolic overnight, and there's a significant improvement in muscle mass gain, especially in elderly patients when they take in protein before bed. And then, of course, it takes strength training and exercise to optimize this as well, because the reality is surgery and critical illness leads to even more severe anabolic resistance. And so it's likely it's going to take more than just protein and calorie nutrition to reverse that. It's going to take nutrients like HMB, which is a leucine-like nutrient that is an anabolic signal for building muscle, oxandrolone, which is an anabolic steroid, and propranolol, which is anticatabolic. And we'll mention those later. Because the reality is we know after an ICU stay of 5 days or more on a ventilator, 60 to 80% of patients are seriously functionally impaired, sometimes for life. But the reality is 40% of major surgery patients suffer major physical impairment as well. And so this is an often overlooked piece that is so essential that we address to give patients their lives back. Now, in the pre-op period, if a patient's found to be at nutritional risk, we would say we need to hold off on surgery if it's scheduled in the next week, and at least for 7 days, give immunonutrition or a high-protein oral nutrition supplement to begin to optimize their nutritional status. And we know that in 7 days, we can make a difference in outcome. So for instance, this is one of many studies that talk about this. This was a study of 800 patients coming for gastric cancer. And what they found was when they randomized a group to preoperative nutrition that included things like oral nutrition supplements and other nutrition interventions versus those that didn't get nutrition interventions, the patients that got preop nutrition for at least 10 days had a 2.5-fold risk of surgical site infection. So even just 7 to 10 days of nutrition, say with just oral nutrition supplements or other interventions, can seriously reduce the risk, significantly reduce the risk of surgical site infection and other complications. Now, if oral nutrition supplements or oral nutrition are not possible, if we can't get at least 50 to 80% of our recommended intake in, we strongly recommend preoperative PN. I think this is something we need to be using more. It's a grade A recommendation of all our society guidelines in the preoperative setting when you can't get the calories and protein in another way. But then the question may come up from you or your surgeons, doesn't TPN increase the risk of infection in surgical and ICU patients? Well, I hope all of you know the answer to this is no, it does not. But I think it's essential that you know this new data. So we know from 4 large randomized trials in journals you've heard of, JAMA, Lancet, New England Journal, in thousands of significantly ill patients that TPN has no association with infection risk in 2022. Again, thousands of patients studied, many good studies in good journals. And these basically show that it's just as safe to put TPN through a central line as it is saline through a central line. They're equally safe. And so why is this? Well, there's a lot of reasons. One is we don't hyperalimentate anymore. We actually now are measuring our patients' needs with things like indirect calometry and other measures. We control hyperglycemia. Virtually all the trials that showed a risk of infection with TPN were when we let glucoses range up above what we would ever do now. When I was a resident, we didn't treat hyperglycemia until the number was above 350 in US units. And so now we would never do that. And so all these old TPN studies didn't control for hyperglycemia. That just started in 2001. And now we give more protein, we have better central line care with our checklists, and we have better lipids. And so we'll talk about that in a moment. So even our guidelines have now caught up. Our 2022 Aspen ICU nutrition guidelines say there's no difference in clinical outcomes between early EN or early PN, and they can be used interchangeably. And so I think this is essential, that we recommend either PN early or EN early is acceptable when we need to deliver nutrition. And again, the clinical outcomes are the same, and this is a strong recommendation. So this is a major shift in the Aspen guidelines, and it's based on this many studies in very good journals that shows the safety of PN. And I'm going to show you even that PN reduces infection risk in surgical patients in a minute. But lipid choice matters to outcome, and this is really essential. If your hospital is still using pure soybean oil or intralipid in your TPN, and I know 60% of US hospitals are still doing that, you need to stop. You need to stop. And your patients deserve better. You need to switch to an olive oil or fish oil PN lipid now. This is essential. And if you want to talk more about that in our discussion after the lecture or during the week, we can definitely talk about how we at Duke did that. We now exclusively use swamphlipid in our patients. Now, in the preoperative setting, we also recommend that preoperative immunonutrition should be considered for all patients, not just malnourished patients, but all patients undergoing major abdominal surgery. If I was having surgery tomorrow, or if you're having surgery tomorrow, you should take this for the week before surgery. And it comes back to the question, could a simple, inexpensive oral nutrition supplement reduce infection by 40%? But first, is surgical infection still a big problem? Well, it is a huge problem still. We know that the cost per infection is enormous, $5,000 to $10,000 per patient, plus the suffering they go through. And you can imagine, Joshua, that was what set off his downhill course. And it leads to a $10 billion a year cost in the US alone. And this is an avoidable, preventable cost that we could intervene with simple things like nutrition intervention with immunonutrition. And what's the scientific mechanism for surgical infections? We actually understand this. We know that T cell count drop after trauma and surgery in many patients. Now, they did a study where they showed in patients after trauma, but this is true after surgery as well, the patients that don't get infections don't have a drop in their T cells. Patients that get major infections have a pretty significant drop on day 3, 2, 3. And patients that die have the biggest drop with significant drops by day 3. Why is this? Well, we know why. We know this because we know that arginine is essential for T cell proliferation. And so I'm going to describe to you how arginine deficiency that is occurring because of the surgical trauma leads to this deficiency in the immune state that leads to post-surgical infection. And so we know that surgery and trauma lead to an initial inflammatory response that the body then has to shut down because it doesn't want that inflammatory response to cause ARDS or kill the host. And so it then generates an anti-inflammatory response that leads to severe depression of severe cell-mediated immunity. And that can lead to infection, that can lead to sepsis, and that can lead to death. And this is produced by myeloid-derived suppressor cells. These are exhausted neutrophils that invade the spleen and invade the lymph nodes and deplete arginine. And so these myeloid-derived suppressor cells deplete arginine in the spleen and lymph nodes, and it's because they express arginase. And the body, as I will tell you, does this to prevent the immune system from overwhelming the patient because we weren't supposed to live after 3 days anyway. So if we give arginine back, we can reverse this and we can maintain immune function. Arginine is essential to T cells, again, ability to function. And so we can reverse this. And so the reality is arginine depletion is induced by the surgery and the trauma. It's not malnutrition. Any of you that have surgery tomorrow or undergo major trauma are going to have these myeloid-derived suppressor cells depleting arginine in your body. And so we need to give it back. And this is something we've evolved as humans since cavemen, because again, if you got attacked by the saber-toothed tiger, no surgeon was coming to save you. If you didn't get up off the ground after 3 days, you were going to die anyway, and the body didn't want your immune system to kill you. And so this is our way of controlling the immune response. But now we want our patients, of course, to live past 3 days because we can save them in the operating room, and we want their immune system to function and them not to get infections. So what's the clinical data for this? Well, there's a lot of it. And this is one of the many meta-analyses that exist. This is a meta-analysis our group did that I worked on. 32 trials, over 3,000 patients, reduced infectious complications by 40%, just using these simple and inexpensive immunonutrition drinks, and reduced length of stay by almost 2 days. You can see there were numerous studies that went into this. Many of these studies are large. They're in high impact journals. There's way too many to even begin to talk about now. This is just a clearly established paradigm, 40% reduction in infections. And again, it doesn't matter if it was given, the immunonutrition was just given pre-op, if it was given pre and post-op, or if it was given post-op alone, it was found to be equally effective. And that's why we encourage to give it before and after surgery. And it works in GI surgery patients, where a lot of the data is, also works in cardiothoracic and ENT patients. And we're trying to increase the surgical groups that this is being studied in. And the key feature here is this happens in all major surgery patients, not just malnourished patients. There was a large trial done in gastroenterology where they studied immunonutrition in only well-nourished patients who had not lost weight. And they found significant reductions in complications and infections in well-nourished patients. Now, you might say, perhaps in the ERAS protocols, we've improved care so much, we don't need immunonutrition anymore. Well, this has been studied as well. This is the ERAS group from Spain. They're a well-established research group that have been doing ERAS a long time. And they compared immunonutrition before and after surgery to just a high-protein oral nutrition supplement. And they found that immunonutrition led to decreases in total complications and reduced wound infections when compared to just high-protein ONS, which is why we recommend immunonutrition even in an ERAS protocol. So the potential cost savings are enormous. And so this is a huge opportunity we have to improve outcomes in our surgical patients. Do I need to tell you any more? This works. We should just be doing it, but do we? In our most recent surveys, we have found that less than 1% of surgical patients are receiving arginine-containing immunonutrition formulas. So we must do better for our patients and get this to them. And you're the ones who are going to take that back and make that happen. So here we have Michelle, significant malnutrition risks, significantly malnourished, clearly. Should we cancel surgery and give pre-op nutrition for 1 to 4 weeks? Well, I think we clearly should have. But again, she was one of those patients that came on a Friday for surgery on a Monday. And despite overwhelming evidence, we weren't able to cancel surgery. And she went on and did not receive preoperative nutrition interventions. So now it's the morning of surgery, and should she get a carb load drink? And what is the evidence for pre-op carb loading? And what's the right way to do it? Well, again, clearly pre-op carb loading is a key part of ERAS, and you want to minimize the MPO period. And there's strong evidence for both of these interventions. So our recommendations say that we should abandon preoperative fasting from midnight, and patients can have solid food for up to 8 hours before anesthesia and clear liquids for up to 2 hours prior to anesthesia. And again, we recommend that the pre-op carb load be 45 grams or more of complex carbohydrate maltodextrin to improve insulin sensitivity. Now, you heard the Lego ERAS people tell you that juice seemed to work, but ERAS people, or the Lego people, are great at presenting ERAS, but they're not so good at reading the literature. And the data that we have only exists for maltodextrin, not for juice, not for Gatorade. And so what's the data? Well, in multiple trials, over 800 patients having major abdominal surgery, using a $3 or $4 pre-op carb load reduces length of stay by a day and a half. Again, this is a cost of $1,500 to $2,000 just in length of stay alone, that these few dollar carb loads can benefit the patient with. Other data has shown it reduces nausea, it reduces pain, it reduces thirst, all kinds of benefits for the patient, including the length of stay benefit. How to do it? it needs to be 50 grams of a complex carbohydrate 2 hours before anesthesia. And if you're in Europe, they give 100 grams of a complex carbohydrate the night before, much like a marathon runner with carb load. And so this is very common in the UK and other European countries, and we do it too. We recommend our patients do this. And it needs to be a 12% complex carbohydrate drink that's low in osmolality, because this has been shown to optimally empty the stomach so the patient has the lowest risk of aspiration and the best emptying to induce this insulin effect. What about sports drink or juice? Again, the ERAS fellows or the LEGO people will tell you you can use those, but the data doesn't say that. The problem is these contain 6 to 7% simple sugars, 6 to 7% carbohydrates, and limited or no maltodextrin. They have often a high osmolality. This is not effective at emptying the stomach the efficient way we want it to. And if your patient's aspirated on one of these things, it would be very hard to defend yourself, because all the literature of benefit exists for the complex carbohydrate maltodextrin drink. And so again, I would not suggest you use Gatorade or juices in this case. The data just isn't there. So, and the other key thing is this needs to be drunk over about 5 minutes. It can't be sipped over a few hours. You need to have your patients drink these. You need to tell your patients to drink these carb loads over 5 minutes to induce this insulin effect. And so that's a key part. Now, many of us thought perhaps adding an amino acid like arginine or citrulline may augment the benefits on insulin concentrations and the benefits for patients. But the reality is, in studies that Franco Carli and other folks have done, amino acids like arginine and citrulline induce nitric oxide and may delay gastric emptying. And so again, we suggest that there's a lack of safety data for arginine or citrulline in the pre-op carb load, and we would discourage using an arginine or citrulline containing pre-op carb load and just stick with the maltodextrin that's been studied, because again, you may increase the risk of aspiration, and we don't have data for these drinks. What about the type 2 diabetic? I get this question all the time, and should we be using carb loads? Well, I can tell you we do at Duke. We do give controlled type 2 diabetics carb loads. And again, we went through the literature, a group of us did, and published a paper on this because we get this question so much. And we ask a few simple questions. Does pre-op carb loading delay gastric emptying in these type 2 diabetics? And we did not find evidence in the few studies that exist that it does. Does it increase the risk of hyperglycemia? And we did not find that there was a significant increased risk of adverse hyperglycemia as well. Again, you have to pick your patients carefully, but in the type 2 diabetics, we didn't see that there was major increases. And then does it improve outcome? And again, we didn't see any increased risks of the type 2 diabetic getting a carb load. And there was one study that showed a significant reduction in length of stay of 2.5 days in the type 2 diabetic getting carb loads. In fact, a lot of the European folks that we talk to from England and other places actually think that it may improve outcomes more in the type 2 diabetics because of the insulin resistance they have at baseline. So again, in type 2 diabetes, reasonably well controlled, these are patients that we do, and we think it is safe to give carb loads, although we need more research, I think, in this area. So again, for the carb loads, we should just be doing it, but do we? Unfortunately, despite the evidence supporting its use, Michelle did not receive the pre-op carb loads before we were doing ERAS. And so she goes to surgery, and now it's post-op day 1. What do we recommend? We recommend a high-protein diet be initiated on the day of surgery, not clear liquids, but a high-protein diet. So either high-protein ONS, pancakes and eggs is a good choice that an old-time surgeon used to tell me, but clear liquids have no place any longer. They only have salt and sugar. They're not good for patients. And we did a really interesting meta-analysis with a group in Australia just about a year ago, where we looked at trials that looked at early protein diets in the first day or two after surgery versus post-op NPO or clear liquids. And we found that an early protein-containing diet led to a 70% decrease in post-operative mortality, a massive effect, massive benefits to the patients. And it reduced surgical site infections, nausea and vomiting, and major complications in these patients. And there were no adverse effects seen. So again, this needs to not just be early feeding with clear liquids after surgery, but early protein-containing diets are essential to best outcomes. And in fact, Ole Lundquist, who's one of the fathers of ERAS, did a really great study on 900 cancer surgery patients where he looked at 5-year mortality in patients who had 70% compliance or better with ERAS versus those that didn't. And he found that patients who got 70% or more of the ERAS pathway components had a 42% reduction in 5-year mortality. So what you do around the time of surgery has significant effects on patients' survival even 5 years later. And what were the key components of ERAS that drove this mortality benefit? Well, there were two things. And number one was oral intake on post-op day one was an independent, strong predictor of 5-year survival. So again, this is critical that this is happening in your patients. The other key predictor of survival was good fluid management in the OR. So oral intake is essential even 5 years later. Do I need to tell you any more? Again, this works. We should be doing it, but do we? Well, we know this is not something that most hospitals are doing. Most patients are NPO more than 3 days postoperatively, still waiting for these magical bowel sounds we know have no relevance to feeding. And again, when we do our surveys, we find that surgical patients are fed more poorly than anyone else in the hospital. It's typically enteral nutrition or other nutritional components are started the latest, typically about 3 days after surgery. We give them the least amount of calories. They get about a third of their goal. And GI and cardiac surgery patients often have the highest risk of iatrogenic malnutrition, are fed the poorest. And so this is something we really, really need to address. We have to be better. So how much to feed our surgical patients? We need objective measurements to guide us. Predictive equations are not accurate. And so with the advent of new metabolic cart devices, we need to be measuring their needs. This is my mom. She underwent a redo double valve cardiac surgery at Duke about a year ago in the fall. And this is Hillary Miller, one of our dietitians, and Yaron Mullinger, one of our physiologists that we work with, measuring my mom's metabolic cart indirect calorimetry 2 days after a cardiac surgery. She was much more hypermetabolic than we would have guessed. And so this can happen now. We have a new metabolic cart that was developed with a group of us of academic physicians, nutrition physicians around the world. Myself and a group in Europe participated, and we worked with industry using a grant from ESPN, the ESPN Nutrition Society, to develop a better metabolic cart. And this is a highly accurate metabolic cart that self-calibrates in minutes, reads in about 10 or 15 minutes. You don't need a respiratory therapist to calibrate it. All you needed for them is to connect or disconnect from the ventilator. And it is portable, affordable, highly accurate. It was really what we all hoped it would be. And so again, there's a huge opportunity now for RD-driven or physician-driven metabolic cart teams. We have an RD-driven metabolic cart team we're developing at Duke, and I can talk to you more about how you can do that in your hospitals as well as we discuss further. But as patients recover from surgery, will they eat enough on their own as they start oral nutrition to recover optimally? Well, we know they won't. We know the average post-surgical intake takes about 700 calories a day, which I can assure you is not nearly enough. And so we recommend post-hospital high-protein oral nutrition supplements in all patients post-major surgery to meet their calorie and protein needs. This was one of the strongest recommendations from the whole group. And the surgeons all said, we know our patients aren't getting the protein and calories they need, and they all need, whether malnourished or not, high-protein oral nutrition supplements for at least a month, if not 3 months, post-surgery. So again, this is critical. She actually did get started on these. And then I often start patients on an anabolic agent too, especially older patients, to optimize their utilization of nutrients. So again, oral nutrition supplements are the only way to deliver the protein and calories that our patients need. And we have a lot of data for this. We know high protein ONS reduces hospital mortality. This is data from a meta-analysis of multiple studies, significantly reduces hospital complications. And in fact, in a 1.5 million patient study from the Premier database, putting an ONS on the tray of a patient reduced hospital length of stay by 21%. In this same study, we were able to show every dollar you spend on ONS saves $52 in hospital costs. So this is a major effect for our patients, very cost effective. And we recommend that getting to an overall protein intake goal is more important than a total calorie goal. And it comes from data like this. This is published in the highest impact factor clinical nutrition journal, AGCN, 115 colorectal patients in an ERAS program in Canada, high protein ONS used to increase protein intake post-op versus a standard diet. And they found that consumption of at least 60% of a protein needs of a patient within the first 3 days post-op led to a reduction of length of stay of 4.5 days. So a huge effect. And so that's why it's so critical that these high protein ONSs are used immediately after surgery. We've looked at this in orthopedic surgery as well. This is an area that there's very little literature in. So we used the Premier database, 900 hospitals, and we found 160,000 hip and femur fracture surgeries. And we found that malnutrition was vastly underdiagnosed, only 8.7%. We know it's at least 30% when you have a dietitian diagnosing it accurately. And we found that only 1.9% of all these patients got any postoperative oral nutrition supplements, and only 5% of the malnourished patients. So this is a tragedy. And we found that giving ONS in these patients led to significantly significant reductions in the length of stay for the patients. So again, in this large study, many hospitals giving ONS to even orthopedic hip fracture patients also had the similar benefits we've seen in the past in other surgical types. Why do we suggest a high protein H&B containing ONS? And again, H&B is a derivative of leucine that's found to be anabolic. It stimulates muscle growth and muscle recovery. That's because high protein H&B ONS has been studied in a large randomized trial. It's one of the only ONS types that's been studied in a large randomized trial and been shown to reduce death by half 90 days post-hospital discharge when it's given for the 3 months following discharge. This is why we use this nutrition supplement preferentially at Duke. And this is what we recommend to our patients, a high protein H&B containing ONS. And you can see at each time point, day 30, day 60, day 90, there were significant reductions in mortality in the patients getting the H&B containing oral nutrition supplement. And for every 20 patients you gave high protein ONS with H&B to, you saved a life. So again, it's hard to argue with that. So again, the use of high protein ONS in surgical patients improves outcomes, reduces costs, and it's the most cost-effective intervention we have available to us, virtually of any of the interventions that we use in medicine. So again, some patients are not able to tolerate enteral nutrition or oral nutrition. And if you have a malnourished patient who's not getting at least 50 to 80% of their goals, we recommend EN, and if not EN, then PN within 48 hours of surgery. And so I think we need to be starting PN much sooner than we do, especially with the new safety data. And so again, and that needs to be continued until patients are able to take at least 60 to 80% of their protein and calorie requirements. And so we need to continue it until patients are really eating well and drinking their supplements. And so again, what does the data say about this, and why am I feeling so strongly about it? Well, there was just a study published about 2 months ago in JAMA Surgery, very high impact surgical journal, that looked at randomizing patients to early supplemental prenatal nutrition versus late supplemental prenatal nutrition in patients having abdominal surgery at high nutrition risk. And they randomized these patients to early SPN within 3 days of surgery versus waiting till day 8, late SPN. And what they found was a significant reduction in infections in the patients who got early supplemental prenatal nutrition. So again, a significant reduction, not increase, but reduction in infections from early PN in these patients. And it was key infections that we care about, things like pneumonia and septic shock and bacteremia, that the early PN improved. So again, this is a major paradigm shift, and I think we all should be using early PN more frequently, and I'm going to talk a little bit more about that in a minute. So again, we must train our surgical patients for the marathon of their lives. And this is really essential. And why do I care so much? Well, you've heard about Joshua, but why do I care so much? And why do I hope you do too? And I know because you're hearing these lectures and participating in this course, I know you do too. And this is why I hope everyone will, and you'll help other people realize this. Because the reality is, how many of you have had surgery? Well, the truth is, everyone in the US, at least, will undergo 9.2 surgeries in their lifetime. Atul Gawande, this is data from him. And so all of us are going to have surgery. Now, some of these are cosmetic surgeries, but everyone's going to have surgery probably multiple times. So someday this will be you or someone you care about, undoubtedly. And unfortunately, I have used up some of all of your surgical trips myself. This was me at age 15, and I've had surgery many times. And in fact, so when I was 15, much like Joshua, I developed ulcerative colitis or inflammatory bowel disease. And that's one of the reasons he means so much to me, and was in the hospital for nearly a year, on TPN for nearly a year, and TPN saved my life, as did dietitians and pharmacists. That's why I'm so close and so passionate about working and increasing the role and prominence of the dietitian and the pharmacist in nutrition care, because they were so essential in saving my life, and they've continued to be that way still for me today as I've been on TPN more than this time. But as a result of IBD, unfortunately, I've undergone 26 abdominal surgeries since age 15, and I now am functionally short gut with 140 centimeters of total bowel remaining. Why did I have so many surgeries? This is the story they never tell you, that when they take your colon out for ulcerative colitis, you're cured of the ulcerative colitis, but now you can have adhesions and bowel obstructions. And I, through my life, have had many of them, leading to more operations. In 2014, some of you know, I had a series of bowel obstructions, unfortunately, the last one resulting in me showing up in my own emergency room with an emergent small bowel obstructions, massive bowel edema, and a lactate of 10, needing to urgently go to the operating room. I came into that surgery probably in the best shape of my life, But despite that, I was hospitalized 23 days and I had an ileus that whole time. I was on parenteral nutrition. And I was writing my own parenteral nutrition with my dietitian team. And I thought, well, I'm very well nourished. I really only need probably 20 kcals per kilo, 1.5 grams per kilo per day of protein. That should be enough. Well, unfortunately, that was not enough. I had a 20-kilo weight loss in 17 days. I went from looking like that picture you saw before to looking like this in just 17 days. I couldn't even walk down the hospital hallway without being short of breath. It was brutal. And so again, I didn't get enough calories. And I thought, to this day, till recently, I believe that the muscle loss and no matter what nutrition you gave, you're going to lose muscle, you're going to get weak. And it took me many years to recover. And so nutrition optimization is part of my everyday life. Because in fact, again, it took 2 years of 4,000 to 5,000 calories a day and 2 grams per kilo per day of protein and exercise and everything else to get better. And I like to show pictures of me with my ostomy because I counsel people with new ostomies, and many of them tell me, oh, my life is over because I have an ostomy. And I tell them, you know what, there's nothing that you could do before that you can't do with an ostomy. And I show them this picture, and I was surfing on the North Shore of Hawaii just minutes before this picture was taken. And I always hope this gives the patients some hope that they can get their lives back too. And of course, it takes exercise in addition to significant nutritional delivery. And so the reality is surgical recovery begins before the day of surgery and continues long after hospital discharge. And so patient recovery using nutrition and exercise and other forms is a personal passion because I knew in 2014 and throughout my life that I would be in the OR and the ICU again. And unfortunately, as some of you know, in February of this year, I began to have bowel obstructions again. And they were quite severe. And one of them happened when we were out of town and away from the surgeons we trust here at Duke. I see a bowel transplant surgeon who's phenomenal at what she does, and I trust her. But most hospitals have never seen a patient like me. And when I started having these recurrent bowel obstructions, we realized I need to have an operation to get this adhesion taken care of because we would be just devastated if this happened when we were out of town. And so I, after much thought with my family, decided to have an exploratory laparotomy on April 20th of 2022. So just April 20th of this year. And I began to wonder, is the weight loss and the strength loss and the muscle loss mandatory following surgery? Am I going to spend 2 years recovering from this again? And I thought, maybe not. Maybe it doesn't have to be mandatory. And maybe with the right sorts of preoperative and postoperative nutrition and exercise, maybe I don't have to lose muscle. And so I went through a lot of different things, including the immunonutrition and all the other things we did. And I took all of these supplements. These have evidence behind them to optimize my outcome. And in fact, I also was put on testosterone because I don't reabsorb cholesterol. And so I don't have the precursors to make testosterone. My level is very low. And so I see a physician who helps me regulate that as well. And started to do lots of training for this using some of the new HIIT training techniques that we're studying here at Duke. And I realized, again, I'm going to have to work hard long after hospital discharge to ensure that I recover optimally. And so I went to surgery on April 20th, and it was a 13-hour surgery. And I ended up having a 20-centimeter bowel resection and a cholecystectomy. I had an inflammatory mass that was leading to this obstruction. It involved my ureter and my gallbladder. And I ended up admitted to my own surgical ICU. This is a picture of me just a few hours after surgery. And I realized rehab has to start immediately. So this is me just 12 hours after that 13-hour surgery, walking around the ICU, walking multiple laps a day. This is April 21st, just a few hours after I got out of the operating room. And we realized too that it looked like I would have a long-term ileus from all of the adhesions and surgical things that needed to be done. And so we started TPN within 48 hours, given the potentially prolonged ileus that I was going to have. And unfortunately, my post-surgical course was complicated. I awoke just a few days later at 2 a.m. with a severe fever, just sweating, and stool pouring from my incision. I developed an intestinal perforation and peritonitis and sepsis, and I had a major bowel leak just a few days later and had to be rushed back to the operating room. So my post-op course was complicated by peritonitis. I had 2 emergent surgeries for bowel perforation, ended up intubated for a period of time, back in my ICU, intubated and sedated in the ICU I actually work in. And I can tell you, this was quite an experience, one that I will never forget. And I developed the thing I dreaded most. I developed a persistent GI fistula and had to have a drain placed, and was told that I wouldn't eat for months. This drain would have to be in place for months, and I may need to have surgery in the future for this. And so I thought at this point, oh my gosh, I'm devastated. I'm definitely going to lose significant weight and muscle and strength now, right? I've been septic. I've had all these complications. I'm going to be on TPN. Again, maybe not. Can we do postoperative and ICU nutrition differently and not have it be mandatory that our patients lose weight and get weak and lose function? If we personalize post-op and ICU nutrition, this is a new era. So again, I was starting early TPN, but this was personalized by indirect calorimetry. You can see me just a few days after surgery underneath the indirect calorimetry hood. Our dietitians measured my needs, and they discovered I needed 3,000 calories a day. Those were my resting needs. Well, I was doing rehab too, and exercise and walking a lot. So they had to add an activity factor of 1.2 to 1.3. So I was needing 4,000 calories a day. Without a metabolic cart, we would have never known this. And again, this was the mistake I made in 2014. I way underfed my needs given my weight and muscle mass and other factors. And so I was getting 3,600 to 4,000 calories a day, 2 grams per kilo per day of protein, and sopholipid. Again, we have transitioned entirely to sopholipid, which is a much safer, much better lipid. You can see TPN hanging there. This is me walking laps around my ICU. I continue the testosterone weekly that I'm on and I'm followed for. And then I was discharged home on TPN, as you can see here, for my persistent GI fistula. I didn't eat for 2 months. And I had to do things around my home. This is my coach, my dog right there. And it was amazing. My wife, I could have never done this without her. She was able to give me all the antibiotics I needed and all the TPN I needed. It's amazing. I could have never done it without her. I'd have been in the hospital for much longer. But again, despite having an open incision, despite having drains, I needed to start rehab and post-operative exercise immediately. So you could see me here riding the Peloton bike, doing light exercise weights. I couldn't lift more than 10 pounds, my surgeon told me, but you can see my open abdomen, the drains, the fistula, the ostomy, and my TPN catheter. And you can see I was finding a way to exercise despite that.
The next time you feel like you can't work out, what do you think of this guy?
And that's my wife in the background. And we hope this inspires patients after surgery that they can do things, they can be active. And in fact, I only lost 5 kilos in that whole period. I was septic and with peritonitis, just 10 pounds, because I got the TPN early, I got the right number of calories, I got the right amount of protein, and I was back to my pre-op weight in less than 1 month. I learned a lot from my occupational therapists about how to do band exercises. This was a much safer way to exercise that keeps the weight stress down on your incision. And so I was exercising immediately at home. 8 weeks after my last surgery, when my surgeon gave me permission to lift more than 10 pounds, my wife and I went back to dancing our Argentine tango routine with many lifts where I lift her above my head, and I was just as strong. And we're going to compete actually here in the next weekend, just about 12 weeks after surgery, in an Argentine tango contest. So look, you can see that I was still able to do all of the lifts that I could do before surgery. So again, the loss of muscle, the loss of strength is not mandatory. And we can do better for our patients. This is not something that has to happen to our patients. And with the right nutrition and the right rehabilitation, we can do this. And I think the reality is we need to be personalizing our nutrition, starting TPN early, using the new indirect calorimetry technologies available. This is essential to perioperative care. And this is the way we recommend that happens. This is a paper I published in NCP that talks about how we need to do multiple indirect calorimetry measures every time there's a clinical change, and at regular intervals, we need to be targeting calories and protein throughout the stay using personalized techniques. And again, remember, our guidelines say that early PN is just as safe and just as effective as enteral nutrition for our patients who can't take the oral nutrition they need. And so we need to be using this earlier, and it reduces infection. And so again, these are all the things now I do after surgery. When I travel, I have to take an extra bag to carry all my supplements, but these are all the things I continue to do. And so my pre-op preparation and recovery is part of every day. And the reality is surgical recovery begins long before surgery and continues long after discharge. How many of our patients will know what it takes to recover? Who is going to teach them? The reality is you're the ones passionate enough to be in these courses, to be in this lecture, and to learn how to make your patients' lives, give them their life back and help them recover. So again, key take-home points. Surgery creates a teachable moment, a chance when people will stop smoking, will treat their diabetes, will improve their diet, will start to exercise, and they continue to do it after surgery, we found. So this is a huge opportunity to really change your patients' lives because they're open to improving their health prior to their operations. They want to train for this marathon of life they're facing. And so to do that, we have to be better. We have to use our simple nutrition Pokey 6. These are the simple things we have to screen. We have to remember there's a team game. We need to get our patients ONS and protein. And again, we have simple pathways you can implement now to do this. If you want to learn more about how you can start an RD-driven nutrition clinic like we have at Duke, our dietitian and our pre-op team wrote a paper on this, which is free to download. It has all our posters, all our pathways, all the stuff you would need, and you can download this paper for free. It's on your reading list. And so the reality is, I hope you take away that no malnourished patient should ever have elective surgery again without nutrition screening and optimization. And the reality is, I dream of a day when this happens and our surgical patients have the opportunity to be best prepared. Because the reality is, if that was happening a few years back, Joshua might still be with us today, perhaps having children of his own. And so I'm going to let the people who do awesome best take us out and listen to what they have to say so we can give our patients the best outcomes.
Yours is so cool and you can't get afraid. And yours is so soft. Don't need IVs.
Yep, that just happened.
What just happened?
Nothing.
Okay. Well then, next time I'll have surgery, I'm having it done ERAS style.
I'll have my skateboard ready.
All right, back to work.
And I look forward to your questions and interacting with all of you through the week. I encourage all of you, if you haven't done it already, to join Twitter and to join Instagram and to follow me and others. It's a great way using these social media sites to learn the latest literature and learn the latest new nutrition care and nutrition evidence. I post all of this to my Twitter and Instagram sites. That's how I've gotten to know a lot of people around the world. It's a great way to interact with your peers. So I encourage all of you to join Twitter and Instagram, follow me, follow your peers, and it's a great way to keep up with the literature and the latest practice. I also am happy to share any of these papers and questions or share these slides with you. This is my email. Feel free to email me at any time. And I look forward to answering your questions and interacting with all of you as we move forward through the week. And with that, thank you for listening and take care.